Thank you very much, Nagwa. And because we are starting 10 minutes late, I won't take the whole 10 minutes, but maybe 5 minutes more, okay? Beyond 11. Good morning to all, and thanks for Badr for inviting me. So today I'm going to talk to you about central eye movements. As otologists or neurotologists, it's crucially important that we recognize central brain pathology, which can explain vestibular phenotype, that is dizziness or balance problems. So I come from the United Kingdom, probably the only one in this conference. I work in Liverpool, which is a beautiful city, and because the majority of the audience is Egyptian, I can tell you, we are extremely proud of Mo Salah. Mo Salah is God in Liverpool, right? And yesterday I met my taxi driver who is Mahmoud Salah, and of course he's very proud of Mo Salah as well. Okay. Sorry, slide is not advancing. Sorry, slide is not advancing. Audio visual?
Audio visual slides مش بتتغير.
Okay. So what are these eye movements? These eye movements are mirrors of not only your soul. We know that. Your eyes betray who you are, what you think about. But your eye movements are also mirrors of what's happening in your brain and in your inner ear. And this was first discovered by Alexander Crumb Brown, who comes from the same part of the world as I do, who's from Scotland, who correctly identified that eye movements are the key. They hold the key. So the most important thing which we need to understand is a saccade. A saccade is a quick, jerky movement in milliseconds which the brain produces in response to either a normal situation or an abnormal situation. So in order to understand central eye movements, you need to recognize a saccade. So why are these eye movements so important? Because they allow you to fixate, they allow you to maintain the vestibulo-ocular reflex, which tells you where you are at a given point of time, which is crucial for life, and they also allow you to gaze hold. Which means that whatever the world is unfolding in front of your eyes, you track those movements pretty much by moving your eyes, which is a very complex interplay of the brain as well as the periphery, primarily the vestibular system. And as a result, these are highly sensitive and specific of if things go wrong, either in the visual system or in the vestibular system or in the central integrator, which is brain. You need to pick these up. You need to observe these. And if you do not have a very resource-intense VNG setup, like many of you would, many of you wouldn't, the mobile phone camera is a wonder of discovery. You can just, with patient's permission, you can actually physically record the eye movements and then transfer it to your hard disk and slow motion it down so that you can accurately. Otherwise, a magnification is recommended either with a standard VNG goggles or what comes as a VNG kit. So it's important, therefore, what I'm trying to say here is, regardless of the kit, you need to have that knowledge and wisdom to look for what you are looking for. So because what the mind doesn't know, the eyes do not see. So how are these eye movements generated? There can be peripheral vestibular problems, there can be central brain problems, and there can be peripheral eye problems. All of them, they mess up the system of integration and stimulation. As a result, they are all over the place and generate all these different abnormal eye movements. So there are 5 types, principles. So there can be a brain pathology, like for example supranuclear. There can be nuclear. There can be infranuclear. Something might be disrupting the VOR and peripheral ophthalmological system. Why am I showing you this slide? This is to tell you that in order to be someone who specializes in central eye movements or any eye movements, you need to have a very thorough knowledge of neurology and ophthalmology. In the United Kingdom, our audiovestibular medicine training program incorporates a very intense stint with ophthalmology in neurology to the point of we actually attend on-call emergencies. Because we pick up these eye movements, we need to know what we are looking for. See, supranuclear, nuclear, intranuclear, and lesions in the ophthalmological system, they are all beyond the vestibular system. Do we need to know them? Yes, most certainly we do. And unfortunately, this is not built in any ENT curriculum anywhere in the world as far as I know. Please correct me if I'm wrong. But in the UK, we are blessed, as I said, we train our residents at least 2 years in neurology and ophthalmology. We are very well versed in ophthalmoscopes. We know how to use the slit lamp. We know all these things, and it's very, very important that you could have a good knowledge. And of course, we do spend a lot of time in neurology. Absolutely, movement disorders, neurology, ataxia clinics everywhere. So this is a given. Anything which doesn't follow a normal is abnormal. So central neurological integration deficits, as I said, they present with abnormal oculomotor movements, and to make things complicated, they coexist with peripheral vestibular disorders. And if you go back to the slide before, you'll see these are very site-specific lesions. And they're exquisitely sensitive. Why? An MR scan or a CT scan, regardless of 3 Tesla or 5 Tesla or a high-resolution cone beam, the lesion needs to attain a certain size in order to pick up the lesion. For example, a brain tumor of less than 2 millimeter will not be picked up by any scan. But the eye movements will be affected because it's at a much more subtle and a smaller level. I have had plenty of cases where I've diagnosed a neurological problem not shown up on the CT or the MR. My neurology colleagues tell me, so what are we looking for? I said, just sit tight, 1 year, 2 years down the line, you will find something when the lesion grows. And lo and behold, that's exactly what happens. So you are the ones who are diagnosing it from a neurotology clinic, remember, and you are not a neurologist. You are diagnosing a neurological problem for a neurotological clinic. So they are exquisitely sensitive and specific, and they share a common phenotype. And of course, obvious neurological problems will present with focal neurological signs, so you need to know how to examine neurologically. And of course, obviously, a frank ophthalmological problem present with focal ophthalmological signs, so you need to get trained in ophthalmology. So there are different types of eye movements. I'm not going to read this, but if you want, and this is my open offer to you, in my laboratory we have recorded 81 different eye movements, majority of them central, all of which told me where exactly the lesion is. Can you imagine? We keep on recording. So this is a wonderful digital archive that we have painstakingly built up over the last 10 years. So let's come to a few basic ones. If the videos play, a disclaimer right away. So a saccade. A saccade is a quick movement which should be smooth when you are using a random paradigm or a fixed paradigm. The way it looks is you get overshoots or undershoots, and this is when the patient is following a fixed target, and as you see, as he's quickly moving his eyes, there are more than one movements. This we call a dysmetric saccade, which you can very clearly see in your traces. Smooth pursuits is when you are following a target, and of course it should be smooth as the name says, and you see this smooth pursuit is broken. And just when I'm not going to describe this, but look at what I've written just under the slides. These are extremely specific. These are sensitive and these are specific. However, smooth pursuits can be normal. So just look at the sites where these things can be generated from. Now this is not like a typical horizontal jerk nystagmus with a slow and a quick phase. This is a very typical pendular motion. And this is extremely important indicator of vestibulocerebellar pathways. So there are numerous pathways between the two. So it's mainly at the posterior fossa vestibulocerebellar, but it can also be at the level of the fourth ventricle in the vestibular nuclei. This is a pure torsional, once again not a jerk movement. This is not a jerk movement. As you can see, this is pure torsional, which is not often found. It can be part of a peripheral disorder as well, for example, acute vestibular neuritis. However, when you do not get a vestibular sign otherwise, and you get a classical torsional nystagmus, it denotes somewhere at the region of the pontomedullary junction. It could be multiple sclerosis, it could be anything. This is a spontaneous gaze-evoked nystagmus. Now, an important thing is, how do you distinguish between physiological nystagmus and a spontaneous gaze-evoked? One is pathological, one is normal. In physiological, it lasts for no more than 10 to 15 seconds and the amplitudes are not huge. In gaze-evoked nystagmus, they settle for a long period of time, 2 minutes, 3 minutes. So one cardinal thing, when a patient comes to you in the clinic, it's not just enough to ask him to look into the finger or a target, watch the eyes for 2-3 seconds and then let go. No, it's not that. This, you'll have to wait for a long period of time. This has also got an upbeat, spontaneous gaze nystagmus. And you can get it in vertical gaze too. You can also get it in vertical gaze. So 9 different positions of gaze. You need to look for nystagmus at every one, and they all tell you a story. A spontaneous, upbeat, top corner gaze evoked nystagmus is diagnostic of a third ventricle syndrome, which we call a Parinose syndrome. That's specific. This kid, this 16-year-old, had a blockage in his aqueduct of Sylvius. So these are by the direction, which is upbeat and downbeat. This is a classical downbeat, and this is a classical torsional downbeat. So it's torting and downbeats as well. And these were all foramen magnum lesions, which are very sensitive to pick up foramen magnum lesions, downbeat. You do get positional downbeats when you are doing BPPV. Central or pathological, always go by the timing. How long does it last? A central pathological nystagmus will last for ages. A peripheral will fatigue after some time. So there are good pointers. So once again, you need to know what you are looking for. Square waves, where Alfragal said, square waves are basically jerk nystagmus, prolonged intersaccadic intervals of more than 200 milliseconds. As you can see, the eyes are moving horizontally, but the break between two saccades is more than what you would expect for a peripheral vestibular nystagmus. And once again, they are quite site-specific. They are not uncommon after head injuries. Sorry, that this is once again a few gaze-evoked nystagmus. So as you can see here, I'll just forward it a little bit. There we are. Huge amplitude. Look at the sclera. If you're looking under bright light, huge amplitude. And then there will be a funny thing when it comes back to normal, and that's when we would call it's got a rebound. So central gaze, no nystagmus. One gaze, huge nystagmus, comes back to the central position, and you will see clear saccades. That is what are called a rebound. So GEN is almost invariably associated with rebound and with abnormal smooth pursuits. That tells you the lesion immediately. You see the rebound there. This tells you the lesion immediately in the vestibulocerebellar region and in the medulla, and also in internuclear, as specific as the interstitial nucleus of Ramoni-Cajal. That's somewhere between the medulla and the pons. So different kinds of gaze evoke nystagmus in different gaze. So this was a downbeat gaze nystagmus, and this was the Parinose syndrome, which I talked about. So always look for nystagmus in all different positions of gaze, not just for a few seconds. Please persevere and persist, because a central nystagmus is continuous. Skew nowadays you can measure. Now very importantly, skew is a part of the Hintz protocol in stroke. But did you know that 1/3 of skew deviations are generated by the peripheral otolith system? So when you get a hyperopia which is up and a hypopia which is down, like a seesaw, that could be coming from an otolith system. Of course, you need to back it up with other tests, as Alfragal said last time, the BEMS and subjective visual vertical and ocular counter rolling and pretty much everything. This is one of the very few opsoclonus that I have seen. It's very specific of the cerebellum's fastigial nucleus. This was a case of toxicity in a teenage girl. So as you see, opsoclonus is sustained and very bizarre and random movements which go on the eyes. They do not follow any pattern like a clonus of your ankle. This is a case we have published, diagnosed from my clinic, imbalance, etc. And all I found was this typical flutter, ocular flutter. He was diagnosed with a sclerotic lesion at the region of his midbrain. This has been published. If you are willing, I can share you with the literature. Now this is an interesting test, VOR suppression. Now as you know that in order to suppress your VOR, you need to physically take an effort to do it. So you are asking the patient to fixate on a target and then moving him in a chair and watching the eyes. The eyes should move smoothly as you move the chair. However, when it doesn't, you get a catch-up saccade. I'm doing this, and you see the catch-up saccade here. This is VOR suppression, VOR cancel, which is diagnostic of a cerebellar flocculonodular lobe lesion. It's that specific. It doesn't come from anywhere else. This was a multiple sclerosis, by the way. Can I take the questions after I finish, please, Alfredo? This is a convergence retraction. So as you ask the person to converge, the eyelids retract and you develop a nystagmus. Once again, this is very, very diagnostic of a midbrain lesion. It goes on for a little time, so I'll just have to, because of time, I can't do it the whole time. Now, internuclear ophthalmologia is an adductor palsy when you are asking the patient to abduct. The abducting eye, in this case, the left eye is showing a nystagmus jerk, and the adducting eye is paralyzed. So paralysis of adducting eye and an abducting eye nystagmus is classical of internuclear ophthalmoplegia, maybe the first sign of early demyelination, not just multiple sclerosis. So this is the summary. They are very specific and sensitive. Some of them can be normal, smooth pursuits, for example, square waves, for example, and they have got definite characteristics in the periphery, which we are lucky, because we can make out what is coming from the brain and what is coming from the inner ear and what is coming from the eye. And the cardinal thing is you'll have to know the normal first very well in order to understand what is abnormal. And you need a very thorough and robust knowledge of not only your inner ear vestibular system, but your neurology and your ophthalmology. So this is the nugget of philosophy. So, as you know, our eyes don't lie, they are windows to the soul. And your patient's eyes don't lie either. I'll just finish with, oh, fantastic, I'm in time, wow. Yeah. So I'll just finish with this small story, which will be very interesting. You know, when Galileo Galilei first published his theory of the earth being moving around a static sun, at that time, Europe was raked with Inquisition, heresy. So obviously, the traditional philosophy was the sun is moving around the earth is the center of the universe. He came and said, no, it's not that. So obviously, he was summoned before the court of religion. And they showed him all the different torture instruments and said, take back what you have said. This was happening in Florence. This place where it happened, where he recanted and said, you are right, I'm wrong, is still there. It's called the Museum of Bargello in Florence. That's the first place where I went. He said, yes, okay, I don't want to be tortured, you know, all those horrendous machines. But then he said, a little bit in a lowered voice, I beseech in all in your humility to trust your eyes. What I have seen through the telescope, I trust my eyes. So I beseech you, you do the same. But yes, you are right, I'm wrong. And then he was let go and he was under house arrest. So my message to you guys, trust your eyes and trust your patient's eyes. They will not lie to you. Thank you very much. Oh, wonderful.
Thank you so much, Professor Gobet. It was really an interesting presentation and very valuable. I have a question. I will take the privilege that I am the chairperson. Is it common to have the ocular flutter in elderly people with white matter ischemia?
I don't think so. Ocular flutter is pathological unless
you don't see
otherwise.
so?
No, I haven't seen. You see, ocular flutter is because of, in order to do that, a little bit of knowledge of neuroanatomy. So these all saccades, they are being generated after the vestibular nuclei have done their jobs, and then they are traveling upstream. So they are traveling through the upper part of medulla and the pons. There you get plenty of saccade integrators, right? The burst neurons, the excitatory neurons, the omnipause neurons, etc. You get some very important signals from example, the red nucleus, the Cajal nucleus. That's where the saccades are integrated, right? And that's how you get a normal saccade. Anything which interferes with this, anything, will actually lead to a saccadic abnormality. Ocular flutter is overactivity of the burst neurons, that is the excitatory neurons. And there are definite causes for it. So there's something must be going on in that region, which is the, let's say the midbrain roundabout, the third ventricle, where the lateral ventricles are going. In my experience, I have seen it happen with a tangible lesion. I haven't seen any ischemic lesion because of that. And your question was, what was the pathology again, what you were saying?
White matter ischemia.
Oui?
White matter ischemia may be due to aging?
Yes, it is a theoretical possibility. Because, but tell me one thing, Nagwa, if that is the case, then why would it selectively affect that area only? If it's ischemia, it should affect the global, right? You should get other signs. But theoretically...
You mean you find another abnormality in the smooth pursuit and saccades, of course. What about if there's only a positional nystagmus, maybe direction changing or downbeating with these flat?
Yeah, that gives you
It's
whole lots of
possible.
clues. Yeah, absolutely. Because ocular, look, all these central eye movements can exist with other things. It's not just one. I have picked up on the single eye at least 3 or 4 different types of nystagmus. All of them told me a story. That's the interesting thing.
Thank you so much.
Alfragal, yes, my friend.
I think we have a couple of minutes for more questions.
I finished well on time.
Thank you, dear friend. I even listened to your central eye movement lecture. I want you to clarify, because I disagree with one point. That is the slide you presented that was taken from the Autometrics, the SHIMP protocol, and you point that this is specific for folliculonodular or some specific central condition. It's just the SHIMP, I have many concerns about the name suppression, because it actually shows a VOR again, so it's actually not suppressed, and confusing it with the clinical test of VOR suppression or VOR cancellation, which you look for saccades, and that is, we cannot suppress the nystagmus, the VOR in the form of nystagmus, not the form of the VOR in the video head impulse. So I disagree with this point. That's why I asked you if you have the saccade from the VNG, not from the SHIMP, because we can discuss 2 hours, 3 hours later on this one, but specifically because this is very important.
Okay, so yes, I do not exactly see why you are disagreeing. That's the first thing, because the slide I show you for VOR cancel is not from SHIMP. Okay. It wasn't from SHIMP. It was from VNG. It was not from SHIMP, and we have got quite a few VNG kits with us. It was not SHIMP. I completely agree with you. The SHIMP is for a different purpose altogether. So that's why I agree. So that's why I said I do not know why you disagree. Okay. So yeah, yes, that is more like, it was called VOR cancel before, because that's what I trained. Now it's called VOR suppression. They follow the same principles. No, I'm talking about the VOR cancel test, where you sit the person on a chair, ask him to fixate, and then move the chair rapidly and watch for the saccade. This has got nothing to do with SHIMP. Absolutely nothing. So now we are in agreement. Hooray. Yes.
Thank you. I think we have to conclude. One more question? Come, please. Last question to Professor Gobita.
Thank you, Doctor, for your informative lecture. I want to ask about the convergence retraction sign, how we can diagnose it, and pathological for what lesion?
Okay, so convergence retraction is basically 2 things. One is you are checking for convergence, where there will be a very clear, the eyes will kind of be drawn inwards. Retraction, as we say, you can see that. That's not the only thing. Then when you ask the patient to look up, he will develop an upbeat nystagmus. So there are 2 components to it. And that is diagnostic of aqueduct of Sylvius syndrome. As I said, Parinose nystagmus. So check convergence, watch how the eyes are moving, right? Up, and you see this nystagmus. That's when you will diagnose an aqueduct of Sylvius stenosis due to any reason. It's pathognomonic, it's to the point, and if you see that with all the other different clinical features, you can talk to your neurology colleague, and your neurology colleague will be very impressed. He might actually ask you to come with him then, yeah.
Thank you, and we have to conclude this session. Thank you so much.
Thank you very much, everybody. Mo Salah, yes. He is God, by the way. In Liverpool, he is treated as God, nothing short of God.